Thank you guys for the invitation. And I don't know, I think a lot of people don't know me. So I was sort of asked to give an overview and just highlights of what I really want to work on. And so that's really nice to just be able to do that. I'm an infectious disease physician. I work in stewardship, but so basically give an overview of kind of what you work on. And so I am a jack of a lot of trades, and probably the rest of that statement fits too. But everything that I do relates to antibiotic resistance, and not everything, right? Because I'm doing a lot of SARS-CoV-2 sequencing, but that's easy. So everything I want to relate to is the country, and did that under a lab license, did it with a lot of rigor and reproducibility. And then, for those who know me, I'm very interested in how antibiotic-resistant bacteria are transmitted in the patient care environment, which has led me to sinks, and then now more recently out into the wastewater. I think my true first love, though, is about how at a molecular level, genes of drug resistance move through bacteria. And so that's kind of how I got started in all of this. And so, let's see if I can. So just a couple of highlights. I'm not going to go through hardly any of this, but just to let you guys know, the way that genes of drug resistance are shared through horizontal gene transfer, and the way that bacteria can evolve rapidly through this, I think it's a really challenging mathematical problem, potentially. It's a really complicated problem, but I don't think it's infinitely complicated. And I think we need to understand how a gene of drug resistance can sit in multiple situations that are mobile and that can then be shared between bacteria. Also, understanding how bacteria are transmitted in the patient care environment is something that we've been very, very interested in, because when we were looking at this multi-species single gene outbreak in our hospital, we could not figure out through genomics, it just didn't make sense looking at the same strain over time, that there was any patient overlap. And the CDC and much of the 90s and early 2000s was devoted to all healthcare required infections are hand hygiene issues. And they are hand hygiene. I'm a huge fan of people washing their hands, however, but that wasn't the whole story, and that was not what we were seeing. And so after a lot of work, we figured out that it's probably premises plumbing wastewater that's contributing a lot. So that understanding that we've been working on and sampling the UVA patient, hospital environment and doing genomics on since 2013, but really following this outbreak since 2007, I've been able to really take deep dives into how is horizontal gene transfer happening in the hospital environment, and then ultimately getting to patients. And so this is a pretty complicated figure that I'm not going to walk through, but basically all the dots are plasmids. And you can see that the KPC plasmid pictured there in red, which we named PUVA01, which we didn't clear with administration in advance, which we should have. But PUVA01 is, shared across all these different clades. And so if you're just looking at the genomics of one bacteria, you would not understand how these organisms are moving through patients, through the environment. But we've been able to take some real deep dives and paired patient data with environmental data. This is just one example of how this can work. And so this was something I did with an infectious disease fellow who's now junior faculty, looking at sort of how do the organisms get into the patient care environment and how do they stay there. And so just very briefly, because this is sort of recent work, I just wanted to highlight how human behavior and human interactions may inform some of transmission. And so we did a study where we had 594 sampling events between June and November of 2017. This was funded by CDC. We basically wanted to take a look at what is making a patient care environment positive for these KPC producing bacteria. So we set it up that we knew some rooms were often positive, some rooms were seldom positive, and some rooms had never been positive, and used that as a reference sampling rooms that we would do with every sampling point. And then if a patient got admitted to the hospital, we would sample their room twice a week along with the reference room sampling. And then we had other sampling during that time period that we used as well to understand this. And so what we found, was that interestingly, a previously positive room here is really what predicts the most strongly that a room is going to be positive, or any site in that room. So toilets, sink drains, P-traps. But we know from our other work in the sync lab that it's the drain that really matters. And what was fascinating was if a patient we looked at antibiotics, we looked at tube feeds, we looked at all sorts of patient factors. And what we found was that if a patient had C. diff, it was actually protective for the drain becoming positive. And what we know about our patient care environment is that if a patient has C. diff, you're not allowed to use alcohol gel. You have to use soap and water hand wash. And so from another video study that we did in the patient care environment, we know that the usage of sinks with municipal water flushing goes way up and likely resistant bugs in the sink drain goes down. So then we luckily have 3 sync labs where we can do a lot of work to understand, what are the dynamics in a sink drain or sink lab to understand this. And so we had a student who did 0 flushing, weekly flushing, twice weekly flushing, and 3 times weekly flushing. We just presented this at ASM Microbe. And if you do at least twice weekly flushing, you basically don't see some of the E. coli that we were studying in this study as a surrogate marker down the drain. We're finishing up with the more resistant organisms, but I think that informs that, if we're going to have these drains in the patient care environment, we should probably flush them with at least, chlorinated municipal water once a week, so they're a little less risky. Lastly, just because the School of Engineering is here, I wanted to show that, we had an EIM that was funded and working directly with Lisa Colosi-Peterson and Erica Loudermilk, who is finishing her PhD in our lab in a collaboration. We looked at, okay, Amy, what happens to KPC or these organisms once they leave the healthcare environment? Where do they go? And there's a lot of people interested in this space, including EPA, NSF. What happens once they leave? And so we did hospital wastewater and non-hospital wastewater primary, just took sewage out, checked it for these types of bad bugs, looked at all sorts of parts along the wastewater treatment plant. I'm not going to pretend to be an expert, but then we looked upstream of the wastewater treatment plant in the river discharge and downstream. And what we found was that, wow, well, first off, there's a lot of different species that carry this because, again, this gene is shared across a lot of different species. So just to orient you, every solid colored circle, we do the microbiology, we do PCR, we're now doing digital drop PCR. Basically, every microbe that has a solid color is carrying the KPC gene. And what you'll see is we don't see them in non-hospital buildings, so dorms or education buildings, but we do see KPC producers coming in high numbers out of the hospital effluent. You also see it coming through all of the wastewater treatment plant until you get to the end. And wastewater treatment in the United States, at least in Charlottesville, seems to be doing an outstanding job at eliminating these organisms, but not 100%. And because we've sequenced so many of all of our patient isolates that we have in hand that have this, we know that this isolate was seen as late as August of 2010 in a patient in our hospital. And the same clone is now downstream in the river. So although our wastewater treatment plant works very, very well, it probably is been, subject to such a load. And so how we then can connect that back to the environment. So they said, what kind of things are you interested in working with the group on in terms of contagion science and antibiotic resistance, but molecular level horizontal gene transfer, understanding the epidemiology of that and what are the pressures that drive that, and then transmission, from the environment to humans and then probably back, and applications of next generation sequencing and metagenomics are always up my alley. So thank you so much for your time. Sorry if I went over a little bit with the